Thank you for the opportunity, especially to ISA Kerala, Chairman Sanjeev and Arif. Um, so basically, when Srijit asked me to do a video, even I was kind of, as Sunil sir said, I was kind of wondering how I'll go about it because we are so busy and whether I will be able to do justice to it. We'll see how far I've come. And secondly, I want to thank specifically Dr. Srijit and Dr. Nasser sir for the workshop yesterday, for giving us the opportunity to be here, and for the hospitality. For this, thanks to my Jubilee team, Dr. Davis, and all those who have helped me along the way. So basically, I hope you. So this is our block room. It's half of the block room. We have 2 ultrasounds there. So this is my patient who's a polytrauma patient, multiple rib fractures with clavicle fracture, posted for clavicle repair, and he's got an ankle surgery also posted. You can see a buprenorphine patch, he's there. We're just preparing him. We've got his consent to do this procedure under as little general anesthesia as possible. We're giving him what was given is combination of midazolam and dexmedetomidine. I'm providing, going ahead with my first block. So the first block which I'm doing here is a interscalene block. I'm coming from medial to lateral here. So first there'll be the needling part and then the video. So under all aseptic precautions and all the other, I don't have the paraphernalia which the time does not permit me to extend on. So we have I've placed the probe, a linear probe, and I'm coming from medial to lateral in this case into the interscalene. So the needling needs to be perfect. Interscalene, the numerous blood vessels around it, chances for nerve injury. Even here, it is going along the path of the phrenic nerve when we go from medial to lateral. So it depends on what you're comfortable with and your level of expertise. So this is the thin guy who's standing there. That is me. And then we have an extension. So the only thing you need to focus on is always use an extension when giving a drug. So only thing you need to focus on is your hand-eye coordination. That is your ultrasound probe and your needle. So if you're trying to inject the drug yourself, almost inevitably the ultrasound will slip out of place and you lose sight and likely to cause further damage. So this is the interscalene groove. So we'll go back to this is the ultrasound representation. I have gone through the so you can see the suprascapular nerves around the subclavian artery. You'll just line up the traffic light signal, and then as you go ahead, what you see there, you can see you'll slowly come in, the interscalene groove comes into view. See, that is your traffic light which you're seeing here, and that is a clearer view. We've decreased the depth, and you can see the needle coming in. And drug will be deposited around the interscalene roots of the cervical of the brachial plexus. So that is the drug being deposited there. Backspace it again. Play. So I'm just trying to hasten it. What is happening is the opposite. So I'll just kind of take it 2 minutes extra, I suppose. That's the only way. So this is the interscalene. This is where we had reached. And so this is the needle coming in. And I'm depositing the drug around the interscalene. Around 5 to 7 ml is more than enough. In this case, I've given around 10 ml because we're doing this only under block. So that was the idea. I'm coming in this case from medial to lateral, not what is usually seen, not from lateral to medial. So here we're using a combination of lignocaine with adrenaline and ropivacaine, 0.25% ropivacaine. That is 0.75% ropivacaine, 20 ml is taken and diluted to 60 ml, so that we can use, I use around 15 ml of 0.25% ropivacaine with a combination of lignocaine with adrenaline for the plus. So the C5 route, there was not enough drug around it. Generally, this is a single needle technique. It is covered with fascia and you just need to give a single dose of medicine. It will engulf all the roots of the cervical, of the brachial plexus. Here I've again come in and given around the C5 root. Now again, we are doing a you can do this under two different blocks. You can do a superficial cervical plexus block, or you can do a specific supraclavicular nerve and an upper trunk block, which is those who are there in the workshop estates, or the SCUT block, that is the supraclavicular upper trunk. Here anyway I've given specifically drug around the upper trunk, that is a C5 root, so I can actually focus on the on giving a supraclavicular nerve block rather than a superficial cervical plexus block. So the difference would be, if you're going for a superficial cervical plexus block, you would be wanting it at the C5 root level, while a superficial cervical a supraclavicular nerve block can be easily done under the C6 root, where there will be two divisions of the nerve, or the supraclavicular divides into three roots. Three different nodules can be seen at the C7 level. So C7 level is closely associated with the vertebral artery. So I'm doing here is a superficial supraclavicular nerve block. So you can see the three roots of the interscalene block, and the area between the posterior belly of the sternocleidomastoid and the interscalene muscles is being targeted. So here it's a very superficial block, and as I said, anyway, if you're doing an awake central line, this is a block which you must do. It makes a huge difference in patient comfort levels. So this is a must block for an awake central line. That is a superficial cervical plexus block. Will cover 4 of the most important nerves there, and you can proceed with a awake central line quite easily if you do a superficial cervical plexus block. In this instance, the first needling went a little deep. I had to pull it out and reintroduce the needle. And this is the needling which is done. Now I'll come back to the ultrasound. Sorry for, I've not been able to present both simultaneously. So you can see in this is a failed block. So this is the area I intend this to go is actually here. The initial area where I had to reposition the needle it comes slightly lower. So the drug delivery was inadequate. So I had to reintroduce the needle just below this sternocleidomastoid. So this is the area where I'm going to do a supraclavicular nerve block, wherein you give an anterior division and a median division and the lateral division. So you can see the three roots of the brachial plexus here and the horns of the anterior and lateral tubercle of the plexus. So this is a mistake, so I have to come back and again do it more superficially. So when all the three roots are visible, generally I am at the C6 level of the brachial plexus, of the nerve root. So at this level, I am targeting specifically the supraclavicular nerves, not the superficial cervical plexus per se. The same block, if I were to give it at the C5 level, it would be a superficial cervical plexus block. So again, around 3 to 5 ml is more than adequate. This will balloon up. It's very superficial And I suggest all PGs when you as it is must use an ultrasound to put in a central line, and then you can kind of do a superficial cervical plexus block initially, come down, and then get your CVP tray ready, and then go in for the um, central line incision. Makes a world of difference. So this is the drug being deposited. For this patient, this is the next block I'm giving. So I'm planning to do the surgery only under regional anesthesia, clavicle repair, under regional anesthesia. Some have been telling me that they do it regularly. Some have been telling me that that is not possible. So, so what I'm doing here is a clavipectoral fascia block. Clavipectoral fascia. So what we will be doing is we'll be giving already the clavicle is to a large extent anesthetized by your by the supraclavicular nerve block and the interscalene. What we are doing added is a superficial pectoral fascia block totally around the clavicle, which will prevent the this will give a double incentive to prevent pain there. So you can see this is the clavicle in the lateral view. You saw how I was holding the probe, and this is a very superficial block, and you can see in the video the needle coming in just at the tip of the clavicle and lifting it up. So you can actually see the spread of the clavicle around the drug around the clavicle. So this is done on both sides of the fracture. So if there's a fracture midway, you do it on both sides of the fracture to get a clavipectoral fascia block. Okay. So once this is done, I am ready for any surgery, provided the surgeon is appreciative of what I have done. The surgeon immediately, the first thing he did was he went and put a needle, tried to suture the towel cloth below the clavicle. I said, no, I have not blocked that. Please wait. You come back. You can use a towel clip here, but don't do a suture infraclavicularly. Yes, so that's fine. So again, this is on the other side. I'm again lifting up the fascia covering the clavicle. So we are doing a clavipectoral fascia block. So here I have given a supraclavicular nerve block, a interscalene block, and a clavipectoral fascia block. This clavipectoral fascia block, I've used 10 ml on both sides of the fracture. Patient has been quite comfortable. So this is the drug spreading along the clavicle. Okay. So once we have given this, the patient is ready for surgery. We can kind of push the patient into the theater. And here we're using a combination of what we call the TIVA starter. TIVA starter, we use a mixture of drugs. I'll come to the end. And we give him a TIVA starter to this thing. So we are preparing a TIVA starter. That is dexmedetomidine, fentanyl, and midazolam. We've given half TIVA starter for this patient. And what happened was initially the patient immediately, as I said, the surgeon hooked below the clavicle to suture the towel cloth. I said, no. By the time the patient got awake, and then I had to give him a rescue analgesia with 20 mg of ketamine. Before I realized what was happening, I said, don't please, I have not blocked that. So come back, you can put a towel clip there. He was more than willing for that. We use Loxicard also in case to just prevent the pain in the vein while we inject the drug. So here we're using around a TIVA starter, a combination of 20 mics of dexmedetomidine, 50 mics of fentanyl, and 2 mg of midazolam. In this case, we're giving around half the TIVA starter we've given for him. And when he had pain, I used a rescue analgesia with 20 mg of ketamine. Already, since he is with all this, we can, he was managed quite well. And then this is the surgery. So this is the TIVA starter being prepared. So you can use an infusion of propofol, you can use an infusion of dexmedetomidine. It depends. The idea primarily when using a block for a clavicle fracture is that the patient should be cooperative. So this is the Tiva starter being given in. And this is the monitoring being done. And for this patient, he had multiple rib fractures. So I've already given an erectus, just continue to see the video. I have already given him an erectus spinae block, plain block, and I've given a saphenous adductor canal block and a pop sciatic block. So two teams are operating, one on the ankle and one on the clavicle. And you can see that the patient is awake, and we have done the whole procedure under block, and patient no intubation, no airway required, no LMA, nothing required. The reason I have not gone into a shoulder arthroscopy, which can be done similarly, is because of the duration of surgery and the patients who are likely to be agitated. So an arthroscopy per se, if it were to last around half an hour and the position of the patient, can be done under block. But when you are considering that the duration may last for 2 to 3 hours, then you profit. So the patient is awake, you put in a mask there, all the monitors are perfectly all right, no hypertension, no hypertension. The patient will have analgesia up to even 24 hours after surgery, and you have given him an erectus spinae block for his rib fractures, for his ankle fractures. We have done a saphenous plus this thing block. So this is my presentation of a clavicle fracture block. So what we give initially, what you saw be given in the block room is what we call MDX. It's a combination of 2 mg of midazolam and dexmedetomidine 10 microgram. So what we usually, half MDX is more than enough in thin patients. And then what we call a Tiva starter, 50 microgram of fentanyl, 20 microgram of dexmedetomidine and 2 milligram of midazolam. And I've used in this patient 20 mg of ketamine as rescue. So the blocks we have used is a supraclavicular nerve block. You can use a superficial cervical plexus block also. An interscalene, a clavipectoral, erector spinae, adductor canal, saphenous, and a pop sciatic. So this is yesterday's shoulder surgery arthroscopic patient, wherein this was done by Dr. Davis also, the whole team. And we have put in an interscalene catheter for post-operative pain relief for a shoulder scopy. The advantage here is that we have given a block with 10 microgram as additive to the local anesthetic, and that implies that the patient had pain relief and needed a rescue analgesia only after 22 hours. In which case we also gave again a low dose of ropivacaine plus thing, and the patient was able to mobilize immediately. The idea is that if the surgery requires a post-operative mobilization, please put in a catheter. The pain would be taken care of to a very large extent, and we can manage patients wonderfully. Patients go home happy. The problem is that fixing the catheter between the interscalene groove is quite tough. So you inflate it with saline and make sure that the tip of the catheter is located properly. And then again, you push through the catheter to see that all the 3 roots are perfectly perfused with your local anesthetic. And then you can fix it, and you can use this for, see this, we're using a perifix of 1 catheter. Actually, we say that this catheter can be left on for 21 days. It's a different polymer. Or you definitely use it for 7 to 10 days while the patient gets the initial course of physiotherapy required for shoulder manipulation. Once again, thank you so much. I'll take any questions from the audience and whatever.
Thank you, sir. It was a very well demonstrated and explained videos. Usually, what we think the clavicle surgeries, as our sir said, we usually combine with block with LMA or GA. But here, sir has done this case only with the regional anesthesia. Here 3 blocks are combined.
3 blocks are combined.
Yes. Interscalene block is given first.
Yeah, you can give the superficial cervical plexus or the supraclavicular block also first.
First.
In this case, we have given the interscalene first.
And why it was from medial to lateral rather than lateral to medial?
It depends on each person's comfort level. So I am comfortable either way. So Davis sir, or some people do it from medial to lateral. Ideally, if your vessels are all lowered down, your carotid and all those things are clearly visible, you can go from medial to lateral.
Okay. So the lower limb also you have given blocks.
Lower limb also.
So total, how much volume was given?
See, actually, volume. One of the misconceptions we have is in the volume of drug. Earlier, when we were giving blind blocks, we used to use 20 ml of 2% lignocaine and 20 ml of 0.5% bupivacaine. Now we are using that says equivalent to 0.5% bupivacaine is equivalent to 0.75% ropivacaine. Okay. Now we are using a 0.25% ropivacaine for the blocks. So in that case itself, only using the bupivacaine's component 60 ml is equivalent for the blind block you were giving. Forget the lignocaine toxicity in the first place. The lignocaine again has been diluted to 1% and you can add a 40 ml there. So actually with the concentration of drugs we are using for these blocks, you can actually go up to 100-120 ml if you are experienced enough and if you have done enough of this without any local anesthetic toxicity.
And clavipectoral, how many
Clavipectoral,
ml?
I have given 0.2% ropivacaine, 10 ml on both sides. So that is also an additional block. So this is ideally you need to give 10 ml. You can do it only. You can give a clavipectoral fascia block for analgesia, post-operatively, all those things. In that case, you just need to give 10 ml. In this case, even 5 to 7 ml would be more than enough.
And what is the difference like in the effect between superficial plexus and supraclavicular nerve?
Supraclavicular nerve will be blocking only the specific supraclavicular nerve. The superficial plexus will greater auricular, or greater auricular, and all the surrounding plexus will be blocked. C1, C2, C3, C4 will be blocked. The whole neck will be blocked with the superficial plexus block. Supraclavicular will block only these nerves. So the medial part of the clavicle, supraclavicular will supply. Superficial plexus at the point of nerves behind the sternocleidomastoid will block 4 nerves and will cover the whole neck. So when you're putting a central line under block, you need a superficial cervical plexus block and not a supraclavicular block.
Okay, thank you, sir.
Thank you so much.
Any questions from
Any
audience?
question, I am more than willing to. This is my area of expertise, so definitely we can share. Anytime you can ask. Thank you so much.
Thank you.